So now we're going to look at a specific example of how you would use the systematic approach to answer a question that gave you drug possibilities to pick from. And in this case, we'll use the same example that we've been looking at of just an agonist, and we call that drug X. And the possibilities are listed here: norepinephrine, epinephrine, phenylephrine, isoproterenol, and low-dose acetylcholine. And what I've written in parentheses to help us, what receptors we should be thinking about that drug having an effect on to stimulate is because these are agonists. So for norepinephrine, alpha-1 and beta-1 agonism is what we want to consider. It has really minimal effects on the beta-2 for our purposes. Epinephrine and the doses that we're giving is going to have more of an affinity for beta-2, so it's going to have preference for beta-2 over alpha-1. And the reason why we make that point is that on smooth muscle in the blood vessels, we have both populations of receptors, so we really want to know which receptors are going to have a larger effect on. And of course, it stimulates the beta-1 receptors as well. Phenylephrine, we're going to focus on the alpha-1. That's what it primarily is going to activate. Isoproterenol is a non-selective beta agonist, so it's going to stimulate beta-1s and beta-2s. And low-dose acetylcholine, in the dose that we're going to give acetylcholine, it's just going to have an effect on the muscarinic receptors, not going to have any effect on nicotinic receptors. Okay? So we have this tracing, and the tracing wouldn't have all these things labeled for us, but they happen to be for our practice session here. And we have these drugs to pick from. We're like, well, where do we start? Well, we already have the numbers listed for us of how to think about stuff. So look at the changes in the diastolic blood pressure. So that's what we would do first. So we see right here, number one, what's the diastolic blood pressure doing? It's increasing, okay? So this is showing an increase right here in the diastolic blood pressure. Now what we're supposed to do is we're supposed to stop and not really go and look at anything else, and we're going to now, what things can we leave in, what drugs can we leave in, and what drugs can we eliminate? So we go over here and we go, well, what receptors would be the relevant ones to pay attention to when we're looking at the diastolic blood pressure? And if you remember, the major determinant of diastolic blood pressure that we think about when we're looking at these tracings is we look at the systemic vascular resistance. And the systemic vascular resistance is going to be affected by the arterial tone. The arterial smooth muscle tone, the receptors there are going to be the ones that we're going to be thinking about. So when we look at the receptors here, for norepinephrine, the alpha-1 receptor would be the important receptor to consider. The beta-1 receptor, that's not on the vascular smooth muscle. So if I stimulate alpha-1 receptors, I would expect to constrict the blood vessels, and that would cause an increase in systemic vascular resistance, and that would cause the aortic pressure during diastole to not fall as much, and I would end up at a higher diastolic blood pressure. So could norepinephrine do this? The answer is absolutely yes, because of the vasoconstriction through the alpha-1 receptor. So norepinephrine is certainly a possibility. Epinephrine, in the dose that we're considering here, has more of an effect on the beta-2 more than the alpha-1. And the beta-2 receptors, they increase cyclic AMP, vasodilate, and that causes the diastolic blood pressure to fall, right? So that would not be explained here, right? The diastolic blood pressure is increasing rather than decreasing. So for epinephrine, we should probably cross it out as not likely. Okay, so we can get rid of it. Because we looked at the diastolic blood pressure, we haven't looked at anything else. Phenylephrine alpha-1, well, for the same reasons why norepinephrine is still a consideration. Alpha-1, vasoconstriction, increased systemic vascular resistance, increased diastolic blood pressure. So phenylephrine is in. Isoproterenol is a beta-1, beta-2 agonist. Well, a beta-2 receptor, like for epinephrine, is going to vasodilate, so that would drop the diastolic blood pressure. So like epinephrine, why we eliminated epinephrine, this is going to be out as well, okay? Low-dose acetylcholine. Well, low-dose acetylcholine, when you give acetylcholine in the low dose, you just activate muscarinic receptors, and the relevant receptor that we would be considering for the effects on SVR would be the M3. These receptors are found on blood vessels. They are on endothelial cells and the vascular smooth muscle. The endothelial effects are really the dominant effect. And what happens is when acetylcholine activates these receptors, nitric oxide is released, and that causes vasodilation and a fall in the diastolic blood pressure. So, low-dose acetylcholine is out. So you see what we did is we systematically went through our one test to narrow our differential diagnosis, if you will, our possible drugs that we have listed here. So now that we've ruled 3 of the drugs out, we have 2 left. So that one test gave us a lot of information that's very valuable in figuring out what's actually going on here. So now we go to the number 2 step. We look at the changes in the pulse pressure. So as indicated here, the pulse pressure, right, is the difference between the systolic and diastolic. It's increased. And if you were given a tracing, you would have to draw this in or just visually see that it's changed. So in this case, it's gone up. So an increase in the pulse pressure is going to be something that we're going to be thinking about inotropic state. That's the big one to think about. And also stroke volume, but as we mentioned previously, the stroke volume, there's so many inputs on it, and things can be going in different directions that they tend to cancel out, and it ends up complicating our analysis in a way that generally is not going to help us. So if we just put the stroke volume aside and we just look at inotropic state, we recall that on the ventricle, the beta-1 adrenergic receptor is the critical receptor that regulates the inotropic state. So we're going to look for, are there drugs that affect beta-1? Well, we've already eliminated epinephrine and we already eliminated isoproterenol. So those would have been a consideration, but we've already gotten rid of them from the first test, the diastolic blood pressure. So we are going to look at, well, the beta-1 for norepinephrine, well, that works. That would increase pulse pressure. Phenylephrine does not have any beta-1 effects, so we wouldn't expect any pulse pressure effects from any inotropic effects. Now, you could argue that there would be effects on afterload and effects on preload, but generally those would cancel out anyway. You'd be increasing afterload, increasing preload, and the effects on stroke volume might just end up washing out. So what we're going to do in this case is we're going to eliminate phenylephrine. So we have an answer. The most likely candidate for this tracing, by just looking at these 2 things, is norepinephrine. Norepinephrine. This is what we've narrowed things down to. So we could stop right here and say we feel pretty good about norepinephrine being the likely drug that was used here, and we wouldn't even have to look at number 3 and number 4 to do this selection process. But what I would like to do is I'd like to go and just go through these steps, because if we end up with an antagonist and then an agonist again, it's a pretty good idea to have a full understanding of what's going on with heart rate, because that could play a role in your decision making for more complicated scenarios. So let's go through what's happening for number 3. Well, number 3 is the MAP is going up, and that's not a surprise. We've increased the diastolic pressure, we've increased the pulse pressure, so of course the mean arterial pressure is going to go up. So on here, let's put our norepinephrine, and let's do it with a different color. So we're giving norepinephrine, right, as an injection. This is not endogenous norepinephrine. This is an exogenous injection of norepinephrine. So the norepinephrine that we've injected, right, the injected norepinephrine, that is going to have a positive effect on the MAP, as we see here. And what is that going to do to our autonomic nervous system, right? What it's going to do is, by increasing the MAP and increasing the parasympathetic system, so we're going to increase acetylcholine release from the preganglionic the preganglionic parasympathetic neurons. We're going to get, and that's going to go through the NN receptor. We're going to get more acetylcholine released from postganglionic parasympathetic neurons, the neuroeffector junctions there on the M2, and we're going to get more M2 activity. Okay, so that would tend to lower cyclic AMP and pKa and lower the heart rate. So that's what number 3 would be. We would say, oh, well, based on the map changes, we would expect the heart rate to go down. Okay? That's what the map changes would tell us. But we also can't forget that this injected norepinephrine is also having an effect here. So even though we have a decrease in sympathetic and a decrease in norepinephrine being released by postganglionic sympathetic neurons, that doesn't really matter because the injected norepinephrine is going to be stimulating these receptors independent of what's being released here, because this is the drug that you've injected. So we're also going to get beta-1 stimulation, and that would tend to raise the heart rate. So we can see when we go down to number 4, the change in MAP was an increase. We were expecting an increase in parasympathetic effects, increased M2 activity, decreased sympathetic effects, decreased beta-1 activity, heart rate goes down. But we also have the direct effect of the injected norepinephrine acting on the beta-1. And that means that the SA node, the beta-1 and M2 receptors are being stimulated simultaneously. M2 receptors from an increase in parasympathetic tone, beta-1 receptors from the injection of the exogenous norepinephrine. So now we go, well, what's going to happen? I have all of this acetylcholine M2 activity and some of this beta-1 activity. What's going to end up with cyclic AMP because they're having opposite effects on cyclic AMP and pKa? Well, we look at the data and we go, well, it's going down. So that tells us that the baroreceptor reflex response, the increase in M2 activity, is beating out the increase in beta-1 activity from the drug. So to summarize the effects that we're seeing here, okay, this increase in, and we can use this color here, this increase here was from alpha-1 effect. This increase in pulse pressure was from a beta-1 effect, okay? This drop in the heart rate is from an increase in M2 activity. This is what we would call the indirect effect, and that was greater than the increase in beta-1, which was the direct effect. So you see how this net effect of it falling tells us that the M2 effect was the winner, all right? And as we mentioned earlier, when we are dealing with these drugs, generally the map changes to a significant enough degree where the baroreceptor reflex wins. Not always, there are some exceptions to that, but that is a general rule. And so this is how you would go about not only figuring out the identity of norepinephrine, and remember, we only need to look at the first 2 steps to do that in this case, but also fully explaining why the changes are occurring, completely looking at the effects on heart rate as we did here. So what we'll do as we move forward is we will look at more complicated combinations of drugs where we have an agonist, it wears off, and then we have an antagonist, and then that causes changes, and then that persists, though that antagonist effect is still on board in the experiment, and then we try the agonist again to see what happens. It's not always so easy to figure out when you have a scenario like that exactly what's going on, and then that's going to build on this initial just looking at the agonist effect, and we'll take more complicated examples as we move along.